Good evening, everybody. We'll just give a moment to let everybody make their way into the webinar tonight. I know we have a big crowd for part one. This is part one, and as a tease, we'll be here tomorrow also. So we're very excited for this Pharmapalooza. So in interest of all of the time that we know we need for all of the pearls that Dr. Lonsberry is going to share, I'm going to kick it off now to make sure we get in as much as possible. So welcome to tonight's Wu University event, Oral Pharmaceuticals in Primary Care Optometry, Part 1 with Dr. Blair Lonsberry.
Thank you. So this is me, and
this is me.
I'm
your host, Dr. Jennifer Stewart, and I think there's just a little bit of housekeeping before we start. So just a reminder, for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There will not be a QR code tonight, so make sure that you fill out the survey link so that you can get your COPE certificate emailed to you. Those will be emailed within 4 weeks. And feel free to ask questions throughout the presentation using the Zoom on-screen floating panels. You can use chat or Q&A. And you can find Q&A on the top if you're on your phone, and chat is behind those 3 dots. So it's my great pleasure to once again introduce Dr. Blair Lonsberry. He grew up in Rossburn, Manitoba in Canada. He obtained his optometry degree from the University of Waterloo in 1996 after completing a Master of Science in Physiology from the University of Manitoba. He completed his residency in primary care optometry from the Illinois College of Optometry in 1997, then joined the faculty at Southern College of Optometry in Memphis. During his time at SCO, he completed a master's in education degree with an emphasis in adult learning. Currently, he's a full professor with Pacific University College of Optometry in Oregon, where his primary teaching responsibilities are supervising interns and overseeing a specialty lumps and bumps clinic. In his spare time, he goes to Anchorage, Alaska, where he sees patients in a private practice. And he has 2 white German Shepherd dogs named Bo and Bennett who keep him sane-ish, plus 4 additional dogs tonight. So if we hear some barking, we know why. It's not just 2, it's 6 tonight. He's a diplomate of the American Board of Optometry, a fellow of the American Academy of Optometry, the Optometric Retinal Society, and the Optometric Glaucoma Society. So with that, once again, welcome, Dr. Lonsberry. I'm going to turn it over to you.
Thanks, Jen. I appreciate it. Disclosures-wise, I do speak for these various companies. And as you all know, I do interactive stuff. So if I can get you guys to log in to Pull Everywhere for me, that would be great. So if you could grab your cell phone and just click on the QR code, that should log you in. And you might already see a question running already. And as Jen mentioned, I have 2 dogs, and Bo and Bennett, and we have been technically doggy sitting 2 dogs since January, which I'm kind of feeling now might be our dogs. And then our neighbors dropped their 2 dogs off. So there are 6 dogs in my house right now. So if anybody walks by, you're going to hear 6 dogs trying to get to them. All right, hopefully I got a few of you logged in. So we're going to do oral pharmaceuticals in primary eye care, part 1. My email address is down below. If you want a copy of my presentation or have any questions, feel free to email me. When you are emailing me and you type in pacificu.edu, it's going to take the U off of Pacific. So if you can just make sure it's on there, then it'll get to me. With oral pharmaceuticals, I think when it comes to topicals, we do topicals really well. We don't tend to think about topicals, but when it comes to orals, I think we tend to kind of hesitate, maybe think twice about. And so what I want to do is go through some of the conditions where I think orals would probably be the best thing for us to use. So let's start with the case first. So this is a 20-year-old male patient presents with a red painful eye. I think when we are having our staff triage patients, we probably should have some form of triage form. When I do go up to Alaska, I basically take the breaks from the school here and I go up to Alaska and practice in a private office up in Anchorage. And There could be anyone. We have 10 doctors in the practice, and there's usually 6 or 7 doctors on at any time. And it's sometimes challenging for the staff to figure out whether or not they should be putting a triage patient on our schedule or not. So we have a red triage form that the staff asks certain questions, and then that triage form has to be signed off by someone, so that the doctors know what's coming in, and it's just not a patient that's thrown onto their schedule and they don't know who's coming in. So with this patient and on our triage form, we have questions like, when did this start? And are you a contact lens wearer? And then other symptoms. So in this case, this patient's not a contact lens wearer. He reports a watery discharge, no itching, and you can see the sodium fluorescein staining pattern that's present. So my first question for you is, what's your preferred treatment for this patient? Again, if you wanted to log in, the QR code's up in the right that you should probably be able to click on. You are not, your attendance and stuff is not being monitored by this. So if you don't want to participate, that's great too. It's just a way for you to participate. All right, let's see what people are thinking. So majority going with oral valacyclovir, and I really like to see this kind of answer here. A lot of times when I do this presentation, I'll get most of the audience choosing both oral and topical. If we think back to the HEAD study, which is the herpes eye disease study, which is probably 30 years old at this point, at that time we had topical trifluridine or Veroptic to treat. And when they added in oral acyclovir to the mix with topical trifluridine, they found there was no additional benefit by adding an oral to a topical. So really what it's saying is that you're equally effective as either doing an oral or a topical. When it comes to treatment nowadays, we know that orals are equally effective as topicals, and topicals can be expensive, and particularly Zergan. In Oregon, the cheapest I can find is about $375 if the pharmacy is actually carrying it. And then if you remember back to what Veroptic or trifluridine is preserved in, it's preserved in thimerosal. And what do we use thimerosal for nowadays? Nothing, because it's toxic. Ultimately, trifluridine can be relatively expensive as well. So when it comes to treatment now, most of us are kind of almost exclusively in orals at this point. They're much more cost effective for your patients, and they're readily available as well. Hopefully, I'll show you in just a minute why oral valacyclovir is probably a better option for you than going with oral acyclovir. Remember that valacyclovir is a prodrug of acyclovir. So they're effectively the same drug, except that prodrugs get converted into the active product in the system. So by doing that, you decrease the amount of degradation before it gets absorbed into the system. And I'll talk to you about that in just a minute. So this is HSV keratitis. So when you see that classic dendrite, that is HSV keratitis. If you tell me your patient has a dendrite, you're telling me that it is HSV keratitis. Nothing else has a true dendrite. Everything else that you see, say with zoster, which is actually a heaped up lesion, as opposed to an excavated lesion, is a pseudodendrite. Same thing what you're seeing with potentially fungal ulcers and those kind of feathery borders, those are potentially pseudodendrites. A true dendrite is with HSV keratitis. If I titer probably everybody on this call, 99% of you are going to titer positive for herpes simplex virus. Now, it could be type 1, which tends to live above the belt, and type 2 that lives below the belt, but it really doesn't make much difference. The genetic similarity between those two viruses is very close. So there's going to be patients who are going to have cold sores and eye lesions that are type 2, and there's people who have genital herpes that's type 1. So it really doesn't make much difference. It's just where it likes to recur. Very few people have any kind of clinical signs of the primary infection. So 90% of patients are asymptomatic. Very few of those primary infections are going to result in any eye issues. So what you see with eye issues is a reactivation. So if they get exposed to HSV1, it goes into the trigeminal ganglion behind their ear, reactivates when they become immunocompromised or sick, et cetera. And then it's typically a unilateral presentation. Bilateral presentations are extremely uncommon. So less than 12% are going to be bilateral. And at that point, we're typically looking at probably more immune abnormalities in patients who have a bilateral involvement. When we talk about signs and symptoms, in symptoms for patients with a red eye, ocular irritation, redness, photophobia, watering, blurred vision. So this really doesn't tell us anything specific about this red eye. There's literally 50 different causes for a red eye. So at this point, we have to kind of look at more of those signs that are going to be present. So in this case, we're looking for that true dendrite. We're looking for central ulceration, which is going to stain with your sodium fluorescein, and those terminal end bulbs, which are the active growth parts, staining with rose bengal or lissamine green. Your corneal sensation testing would be reduced in this eye. And for the most part, I don't generally do that. If I see this, then I know what this is, right? So I don't necessarily need to do corneal sensitivity testing. However, if I see this is a geographic or an amoeboid ulcer. This is much more difficult to diagnose. So if you see this, you're going to go, okay, and put some stain on it. Yep, stains with sodium fluorescein. If you put lissamine green on it and it also stains, then HSV needs to come to the top of your list. At this point, I'm probably going to do corneal sensation testing to see if it's reduced. And the other thing that you want to look for is if there's an anterior chamber reaction. So say there's an iritis. Typically, we think about iritis, acute onset iritis is resulting in a decrease in IOP. The exception to the rule is herpetic lesions. Because it results in a trabeculitis, they have an increase in IOP almost instantly. So if you're seeing this lesion, you're seeing an anterior chamber reaction, and it's elevated IOP, then again, you're going to start thinking more herpetic infections. If you talk to any corneal specialist, they're going to assume any lesion that's sent over to them is herpetic until proven otherwise. They say it can look like whatever it wants. It doesn't have to have that classic dendrite. They assume it's herpetic until proven otherwise. All right, my next question for you is, what's the proposed recurrence rate of HSV keratitis in the pediatric population? I'm not really monitoring the chats at this point. I got a lot of slides to get through at this point. So I'm probably going to answer questions at the end, just so I can try to get through all the slides. So I'm not too sure what the chats are coming up at this point, but if you can kind of hold on to those questions till the end, that would be great.
So far, no questions in the chat. So
Perfect.
I'll be watching them and we'll take them at the end, but so far we're good.
Thanks, Jen. So the correct answer is D, is 80%. And so most of you are choosing 20%, and that's half of what the adult population is. Adults are about 37 to kind of about 40%. So kids are double that. And why are they double that? Is because they actually have a hyperimmune response. So kids go stromal 75% of the time. Adults stay with that epithelial keratitis. Very few adults go stromal, and it's the stromal adults that also tend to recur. Because kids have this hyperimmune response and they go stromal, they have a much higher recurrence rate. Also, just think you have a 2-year-old comes in, they're going to sit perfectly in your slit lamp. You're going to put your stain in, they're going to open them nice and wide, and you're going to be able to see this lesion. Kids are also hard to examine. So there's a higher misdiagnosis rate in this group. So the thought is, if you have a recurrent unilateral red eye, then HSV needs to come to the top of your list. The concern with this one is because they go stromal can result in scarring, which can then result in weird forms of astigmatism, or they can develop meridianal amblyopic components. So be a lot more cautious in the pediatric population. So traditional treatment's been topicals. Viroptic's been our mainstay. My pet peeve is it's not 9 times a day dosing. It's every 2 hours to a maximum of 9 times a day. If a patient's taken, Viroptic 4 times and at 6 o'clock, I don't want them taking it 5 times at night because it's just way too toxic. Zergan, a lot less toxic, a lot more expensive. Its dosing's 5 times a day until the epithelial lesion heals, then drop it down to 3 times a day for the remainder of the week. We have to remember what happens to a pill when we swallow it. When we swallow the pill, it's obviously going down into the gut. Tends to get broken down either by the GI or in the intestinal lining. And then it has to be absorbed into the system. When it gets absorbed in the system, it goes to the liver. It goes to the hepatic portal system. And when it does that, it goes through what's called first pass clearance through the liver before it ends up in the circulation. So that's really important. A lot of drugs are broken down by the gut, so they're really intended to be absorbed by the intestines, whereas there's a 1,000-fold increased chance of being absorbed in the intestines versus the gut. And what you want is, what companies spend millions of dollars on is trying to figure out what's the best way to get the highest concentration into the system by swallowing a pill. If you want to bypass that system, so people who are addicted to drugs are not swallowing oxycodone, they're crushing it and snorting it or injecting it because they're bypassing the liver, getting 100% bioavailability in the system. So when it comes to oral antivirals, this chart I think is just a great kind of summary of what we're talking about. Acyclovir. When you take acyclovir, only 10 to 30% gets absorbed into the system, which means its bioavailability is about probably 20% of what you take in, which is why it's 5 times a day dosing. In order to be able to keep levels high enough, you need to take it more often just because it gets metabolized really quickly and there's just a lot less in the system. I tend to remember zoster dosing because simplex is technically half of that. So for acyclovir, it's 800 milligrams 5 times a day. Simplex is 400 milligrams 5 times a day. For all of these, I honestly really don't care if you go with the zoster dosing for everything. You're certainly not going to hurt the patient by doing zoster dosing unless they have kidney issues or something, then we'll be a little more careful about that. But by giving zoster dosing for simplex, you're just getting more medication into the system. With valacyclovir, remember it's a prodrug of acyclovir, but it gets converted in the system. So it gets converted at a 95% conversion rate. So now you're going from bioavailability of 20% to probably 70%, which again is why its dosing is much less. It's 3 times a day. It's absolutely my preference on medications to give. When valacyclovir was Valtrex as a brand name, it was $25 a pill. So that would have been $75 a day for treatment. Well, now that the generics are available, it's much more cost effective for patients. Now, famciclovir is not a drug I've ever prescribed. It's actually a prodrug of penciclovir, which is about 10 times more active than acyclovir. It's not a drug that I've used. It tends to be one of those drugs where if the patient's allergic to acyclovir, so you can't give acyclovir or valacyclovir, or either of those 2 drugs haven't worked, then we'll consider doing famciclovir. Stromal disease. This is when we have inflammatory complexes in the stroma. This is the one we get really concerned about because now this is going to increase the chance for patients to scar. When stromal disease happens, it also is the one that tends to recur as well. And patients can have stromal involvement and not have the epithelial defect. However, if you say start treatment with steroid, they're going to develop an epithelial defect. Well, remember what you learned in optometry school was that you never put a steroid on what you think is an HSV infection. Well, I'm going to modify that rule a little bit and say, don't put a steroid on what you think is HSV unless an antiviral is in play. You need an oral antiviral in play for stromal disease. And you can see down below that it makes no difference whether there's an epithelial defect or not. You need to put a steroid on it, but you need the oral antiviral in play. And why the steroid needs to be in place, because if the stroma scars, then patients are going to have reduced vision. The head study used prednisolone phosphate. We don't really use predphosphate for anything, so you need something stronger. You can certainly do 1% pred. You can do Lotemax. FML is one of my favorite steroids to use. And you're going to do probably pretty high dosing for the first couple of weeks, but look at your treatment period time. It can be upwards of 10 weeks. Now, that's not full steroid for the entire 10 weeks. That's probably, high dose steroids for a couple of weeks and then a really, really slow taper after that. But you're going to need to be on the oral antivirals for the entire time period as well. So treatment regimens, if you're going to go topical, then I would go Zergan. My mainstay is really oral valacyclovir, typically 500 milligrams 3 times a day for 10 to 10 days. Now, again, if you want to do the zoster dosing of 1 gram 3 times a day, I really don't have a problem with that. L-lysine. L-lysine has antiviral replication properties to it. I've never used it as a treatment option, but I have used it for prophylaxis for patients, which I'll talk to you about on the next slide. Debriding the ulcer. This means basically what you want to do is get rid of those active viral particles that are there. So no algae brush, no golf club spud, no needles, nothing sharp. What you really want to do is put piperacane in the eye and then literally like a cotton swab and just peel off that necrotic tissue. And by doing that, what you're doing is speeding up the healing time. They don't heal better. The end result's not better. They just get to that end result quicker. But please remember, no sharp instruments, no algae brushes, no golf club spuds, no needles, nothing sharp. Prophylaxis. If you remember back to the head study, they did a year basically follow-up on those patients after the trials, and they looked at patients who weren't taking prophylactic medications and those that were, and they found that the patients taking prophylaxis had a 50% reduction in developing another flare-up. Now, remember, though, that adult patients only flare up about 37% of the time. So it drops them down to about 18%. And as soon as they stop taking the medication, then their chance for developing another flare-up goes back as if they've never taken the medication ever before. So a lot of us, when that first results came out, all of us were putting patients on prophylaxis to realize that we have a 20-year-old in this case, we're going to say for the next 70 years, you're going to take this medication every day and you're not going to miss a day. Well, the likelihood of that happening is remote. And we're dealing with a virus, and viruses adapt very quickly. So there's really kind of 5 major groups that we tend to recommend prophylaxis for. The pediatric group, because the fact that they have such a high recurrence rate, they need to be on prophylaxis. The downside to the pediatric group is we don't know how long. The minimum time period is probably a year, but probably closer to 3 years. And then you're gonna have to watch them really closely. If they come off of that, they might flare back up on you. If a patient's had previous bouts and have scarring, they need prophylaxis. Your patient has a PK or a corneal graft, develops an HSV, they need prophylaxis. Patient is monocular, and the other one's binocular involvement. If there's bilateral involvement, then again, I'd be looking to their immune system, but they're likely going to need prophylaxis. Now, allyl-lysine I've used for prophylaxis in patients. I live in Oregon, so kind of lots of crunchy granola people here who really don't want to take medications, and I don't blame them having prescription medications all the time. So I will prescribe allyl-lysine for them. It's 1 gram per day. It's an amino acid supplement, which they can get on Amazon. I typically get asked about the issues with kidney function and the antivirals, and there's certainly a concern for that. If patients have kidney issues, then I certainly would be talking to their endocrinologist or their renal doctor or their PCP. But for the most part, in, say, respect to acyclovir, you need to be almost an IV dosing in order to kind of get the concerns for kidney issues with the antivirals. But you do need to make sure that if you're doing the prophylaxis for the patient, that you order kidney testing done every year, because that will be your responsibility. Now, generally, I'm going to run that through the primary care physician, but if you're ordering the prophylactic medications, then make sure that you're getting the kidney testing done. And remember our big 3 kidney tests: serum creatinine levels, BUN, blood urea nitrogen, and GFR, glomerular filtration rates. Remember our 2 big liver tests, ALT and AST. All right, so some of the pitfalls to prophylaxis is the fact that this is a virus and they adapt really quickly. So they've already found patients who have developed resistance to acyclovir for HSV1. So again, kind of really recommending it for those 5 major groups. All right, here's my next question for you. We have a 75-year-old patient presents with blisters on his forehead and nose and the following ocular presentation. What's your treatment? All right, the teacher said. So majority going again, oral valacyclovir, and I would agree in this case. With this being the potentially the keratitis component to herpes zoster, your topical trifluridine is not going to work. You need an oral medication in the mix in order to treat this. So you need to treat it systemically wise. No one put topical steroids, and you can actually put a steroid on this, but you need your oral antiviral in play in order to kind of take care of the condition. But to get rid of that keratitis component, you absolutely can put a steroid on it. But again, you need the oral antiviral in play. So herpes zoster, this is a reactivation of the chickenpox virus. So if you're like me and older like me, you likely had the wild type. And you probably had, chickenpox parties where if someone in the neighborhood got chickenpox, your parents went and rubbed you up against them to make sure you got chickenpox as a kid. Now there's a vaccine for it. The reactivation of this virus gives you the zoster or shingles, and you can technically get it with the vaccine as well, but the chances of that happening are much reduced versus the wild type. Highly contagious, develops that macular papular rash after about 5 days, which is then crossed over. 96% of people develop it by the 20 years of age. The reactivation is the herpes zoster or the shingles. I developed mine when I turned 40, and I got mine almost the exact same area as this person here, kind of the T3, T4 area. Sad part about it is I lecture on this stuff and I was really pretty clueless. I thought I just recently started running again, was getting a rash, but should have figured out it was numb, not painful. And when the blisters start to break was the worst pain I've ever experienced. It's kind of like someone taking an ice pick and just stabbing me. I actually slept on my bathroom floor for about a week because it's the only place I could get comfortable. It used to be, we thought more elderly patients. So if you're under the age of 60, we thought that you should be worked up. Then it was under the age of 40, which is what this says here. But now, honestly, they're not working up really anyone. If you're probably less than 20, they might consider it. But the new demographic for zoster patients is 20 and 30-year-olds. So it's not something that we really work people up for anymore. And it's not really kind of relegated to these patients who are older either. Now, the post-hepatic neuralgia that patients can develop is much more of an older demographic. So your chance of developing post-hepatic neuralgia over the age of 50 is much more significant than if you are in your 20s or 30s. So these graphs are just showing you that there is definitely a decrease in age that's presenting with herpes zoster, but you can see that post-hepatic neuralgia is still in patients generally over the age of 80. Presenting symptoms in patients, they tend to have a kind of a prodromal syndrome with this malaise, tiredness, fever. They tend to get tingling sensation, paresthesia in the area of the dermatome that's going to be affected. And the signs are the maculopapular rash, so the vesicles that develop on the dermatome area. And we tend to think about Hutchinson's sign, and we always think about Hutchinson's sign as lesions down to the tip of the nose. Well, they can really be on any part of the nose. On the side of the nose down to the tip, much more dramatically increases the chance for them to having ocular involvement to go along with it. The most common ocular manifestation to zoster is actually uveitis. We tend to think more the keratitis, but it is really uveitis. So if you do have a patient that has the lesions on their forehead and they're going onto the nose, really go look for an anterior chamber reaction, which is what you might be missing in these patients because they're not necessarily comfortable for you to examine. Just make sure that you're not missing an anterior chamber reaction. So a person's risk for zoster increases sharply over the age of 50. About 1 in 3 people in the US will develop it. A person's risk of developing post-hepatic neuralgia increases sharply with age. So at 40, when I had mine, the likelihood of me developing post-hepatic neuralgia was not great. The older you get, the more likely that could happen. And I can guarantee you that if I had that pain that lasted for the rest of my life, I would not be dealing with that pain very well. So treatment-wise, again, valacyclovir would probably be my choice in this case. 1 gram 3 times a day, or famciclovir at 500 milligrams TID. Some thought that these 2 medications would probably be better than acyclovir, that because they're higher bioavailability in the system, that they're much better at kind of managing the condition, potentially some loss of or decrease in chance of developing pain, etc. Don't know the studies are overly conclusive on it, but I certainly don't think it hurt to go these routes just to make sure you're getting the most in the system. Effectiveness of therapy should be started within the first 72 hours. I am finding some primary care doctors not doing that if they're coming in past the 72 hours, but I don't know why. I was definitely past the 72 hours and my PCP still treated me. I think it decreases the number of eruptions of those crops of lesions that you're going to have, and I would still recommend treatment for those group. Management of pain, typically we're looking at, say, things like tricyclic antidepressants. Gabapentin's probably the most common that you tend to think about for management of pain in these patients. And you can use a steroid for the ocular complications for these patients, not only for the uveitis, but also for any keratitis that's present. I don't have a slide on this one, but I was lectured at Vision Expo this past weekend, and one of my former students came and talked to me after and said that he has this patient that keeps getting these kind of recalcitrant flare-ups of this keratitis. And I'm hearing an awful lot of that from doctors after I get presentations coming and saying they just have a patient that just smolders all the time. They can't seem to get them off the steroids. And we're seeing more and more of that. They need to be on the oral antivirals. And my only suggestion for that one is to try topical Zergan over top. Some evidence that might help to get rid of that keratitis that's there. And when it resolves, you typically don't want to keep this patient on the steroid forever. Some thought to potentially try something like cyclosporin to try to reduce again as an immunomodulator. And the other thing I was just thinking about, and I need to email the former student, is I was thinking about potentially, because we get increased chance for neurotrophic ulcers with zoster, is if you're getting that staining, that kind of keratitis part, is maybe to try oxybate on those patients to see if that resolves, because this actually could be the beginnings of a neurotrophic component. So something that I would think about in that, and I should actually really email that doctor. Speaking of oxybate, this is only FDA-approved product for the treatment of neurotrophic keratitis. As you can see in that picture to the right, that's development of basically a full ulcer in that case. But remember, neurotrophics come in stages 1, 2, and 3. Your stage 1 is kind of that SBK, then stage 2 is the deeper kind of PED type lesions, and then you get into your neurotrophic ulcer. Remember, this is through Dompe. They have a kind of concierge service on that one. Whenever you prescribe it, you really should be registering the person with Dompe. At that point, then Dompe kind of kicks in and kind of takes over the process. When the prescriptions try to be filled out, if it gets denied, then Dompe kind of steps in and starts, reapplying for it, and then we'll potentially get the patient on a patient assistance program, and for as little as $50 for that. This is 6 times a day dosing for 8 weeks, but it shows significant improvement over not doing kind of anything at all for these patients. One of the doctors up in Alaska, Dr. Liz Lane, has had several patients that she's put on oxybate, and it's worked really well. So keep that in mind for these patients, particularly those patients that may be having that recurrent keratitis as well. There is a vaccine for zoster, and it's called Shingrix. It is indicated for healthy individuals over the age of 50. And I get a lot of questions like saying, well, I've had my zoster when I was 25. Can I not get the vaccine? And the answer is no, you can't. They will do it in very specific instances where they feel that there's patients, at a higher risk because they're immunocompromised or some other reason, but they won't give it to you under the age of 50, even if you've had previous bouts of zoster or shingles. And the reason why is because, first of all, it was only tested in patients 50 and above, but also your chance for postherpetic neuralgia dramatically increases over the age of 50. So we don't necessarily know the lifespan of that vaccine. So say it starts to wear down or not be as effective after, say, 10 or 15 years, we don't know if we can re-give the vaccine. And if we gave it to you when you're 25 and it wears off by the time you're 40, well, the chance of you developing postherpetic neuralgia is not going to happen until you're in your 60s. So they don't want to wear off that potential for reducing postherpetic neuralgia. It is 97% effective in patients from the age of 50 to 69, 91% effective for patients 70 and above. But the next statement is the big one for me. It's 91% effective in preventing postherpetic neuralgia for people 50 and older, and they know that. So they don't know what would happen if they gave it to someone who's 25. So I've had mine done. Typically, if you've had a bout of shingles, you have to wait at least probably a year, but probably more a couple of years before you can get the vaccine, because your body sets up its own immune response to it. It is a set of 2 injections, usually separated by about a month or 2 in between. I will tell you, the first injection I had, I really didn't have any side effects to it. The second one, I felt like crap. I really felt I had the chills and the fever and the shakes and the shivers, etc. So I would just potentially warn patients that they're going to probably go through that, but it lasted a day and it was gone. All right, my next question for you. So this was a patient I had during my residency. I was on emergency call, got a call from a lady in the morning that she rolled her curling iron onto the front part of her eye. So rolled it right onto her cornea. She's ranked her pain 8 out of 10. It was actually kind of amusing. She said to me, I said, so you're on your way in, right? And she goes, oh no, I have to go to work today. I'll see you about 4:30. And I'm going, yeah, I don't think you're going to make it to 4:30. So by like 8:30, she was already in the office because she couldn't stand the pain anymore. So what are you going to recommend for pain management for her? I know there's a lot of answers on here. So kind of scan through them kind of quickly and tell me what you would do. All right, let's see what people are thinking. Some chose enucleation. Thanks for playing. I appreciate it. But you chose enucleation over giving a bottle of Preparecane. Now, I find that highly amusing. Who gives a bottle of Preparecane or Tetracaine? Urgent care, emergency rooms do. And why they do it is because of this study. So this study, which came out in the Emergency Room Journal, says that topical tetracaine given every hour is found to be safe and effective for patients who have an uncomplicated corneal abrasion. Double-blind, randomized clinical trial. Sounds really official. Sounds super good, right? Except that they don't actually read the study. The study is actually a compounded product of tetracaine. It's not what you get in a bottle. The study has also been refuted. In addition to that, if you actually read kind of in between the lines of the study, more patients were likely to develop a keratitis if they were on that. So yeah, patients are going to love it, except they're going to have no epithelium left after it. And if you don't think people are doing that, they absolutely are. Up in Alaska, when I was up there, this maybe Christmas, not this past summer, we had to remove 2 bottles of tetracaine from patients that were given to them in urgent care. So please tell your urgent care physicians not to prescribe this. Send me an email. I'll send you the study. I'll send you the refuted study, and I'll send you 20 articles where they're going to remove the epithelium. All right, so most choosing the acetaminophen 2x325 and 2x200 of ibuprofen. And I think that's a great way to prevent patients from kind of getting back into pain and maybe managing the 5 to 6 on a scale. But 8 out of 10 is a tricky one. And I chose that because that's what the patient said. But in addition to that, when I had surgery about 6 years ago, when I woke up from surgery, they asked me how I felt. And I said, I felt like crap. And they said, rank your pain. And I said, 8 out of 10. And they said, okay, we're going to give you morphine because I was hooked up on IV. Well, it took care of my pain because it stopped my breathing. Well, if I'm not breathing, I'm probably not feeling much pain at that point either. Because I was coming out of sedation, remember your opioids shut down your respiratory centers, particularly when you go sedated, you just stop breathing. So I had a friend in there with me and he sat there and pinched me literally for 2 hours to try to keep me awake. And I kept on going, you're pinching me. I don't understand why you're pinching me. I was just in surgery. Why are you pinching me? And he goes, because I'm trying to keep you awake, because every time you go out to sleep, all the alarms go off and everybody freaks out. So really to manage 10 out of 10 pain, you really need to be into the opioids, but then you're dealing with the side effect profile of opioids. If you're less than 8, then I think acetaminophen and ibuprofen would work great, but I don't know whether or not to give you over that pain threshold at 8. Now, the next one would. So 1,000 milligrams of acetaminophen plus 400 milligrams of ibuprofen given at one time is equivalent to 5 milligrams of hydrocodone. So that's what emergency rooms are really defaulting to now. Instead of going with an opioid, is to give 1,000 milligrams of acetaminophen plus 4 milligrams of ibuprofen at one time. And that is pretty amazing for pain relief. My roommate, who tends to have a lot of pain issues, didn't believe me on this one, and I told him to do it, and he goes, oh, that worked really well. So that's what I would probably do in this case. Now I would do that. At that time, when I had this patient, we did Tylenol 3. Hi, my name's Blair. I love codeine. Codeine works really well for me. And why? Because it kicks in so quickly. It kicks in within about 20 minutes. Peak activity is about an hour to 2 hours in, but it kicks in really, really quickly. So I think Tylenol 3s would be certainly appropriate for this patient. I can prescribe Vicodin as well as oxycodone. I've never felt the need to do that. I'm glad we have the ability to do it because I do think there's cases where it's certainly indicated, but Tylenol 3 is kind of the max I've ever gone. So let's quickly go through pain management, because I do think this as part of the orals lecture is really important for us, because patients who come in on pain want their pain managed now, and they want it over a 24-hour time cycle. They don't want to wait for pain management, and they don't want to be pain-free for, 16 hours and then in pain for 8. So conditions we would want to consider it for, things like corneal ulcers, simplex zoster, thermal burns in particular. Thermal burns have a lot of inflammation associated with them, so they really continue to activate those nerves, so they tend to be really extremely painful for patients. Acetaminophen, one of our mainstays for pain management. Not exactly sure how acetaminophen works. They think that it has a kind of a central nervous component to it. Has very little impact on inflammation. So the take homes for acetaminophen, good for pain, good for fever, no effect on inflammation. So if you need something anti-inflammatory, you're going to need to do like an NSAID. There's all your different pills that are available. It does also come in suppositories and IVs and et cetera, but you're likely going to be prescribing the orals. Your regular strength Tylenols, the 325s. I'm a big fan of the extra strength Tylenols, but remember that they're 500 milligrams. So typical dosing's 2 of those, which means that you're at 1,000 milligrams. The original daily dose max for acetaminophen was 4 grams. It's now 3 grams. They're finding the most common cause for acute liver failure in the US is secondary to acetaminophen overdosing. And there's 50 different products that patients can be taking that have acetaminophen in it. So they can be taking acetaminophen, but if they take NyQuil, it's got acetaminophen in it. They take Midol, it's got acetaminophen in it. So be really cautious on this one. Really not pushing for more than 3 grams per day, which means if you're doing that 1,000 milligrams, you really need to be on that 6-hour schedule. So, basically that's every 18 hours. Hopefully the patient's sleeping for a few of those hours, but you don't want them to be pushing beyond that. Acetaminophen and NSAIDs have what's called a ceiling effect. So remember back in your pharmacodynamics and kinetics, that there's that Tmax curve, right? So as you increase the drug, increase an enzyme to basically it maxes out. Well, that's your ceiling effect. So at that point, once there's a maximum amount of drug in the system, it can't process the drug any more than that. So if you give any other drug in that time period of say 4 to 6 hours, then all it is toxicity. They're getting no additional benefit from it. So really make sure you're explaining to your patients that if they take it, they can't take another one for another 4 to 6 hours because of the fact that it's just going to be toxicity at that point. NSAIDs, drug of choice for mild to moderate pain, again, has a ceiling effect like acetaminophen does. There is effect on inflammation, which is beneficial. There is variability amongst the NSAIDs. So it's much like your prostaglandin analogs. If you try one, it doesn't work, then try another one because it might. Ibuprofen and little brown pills, maximum you can get over the counter in the US is 200 milligrams. If you happen to be on the call from Canada, you can get 400 or 600 over the counter. This one is the most renally toxic of all the NSAIDs. So be careful on patients who get to maximum dosing of that 1,200 milligrams per day. If they are on blood pressure medications, in particular diuretics, it will start interfering with their diuretics. So just be cautious on max dosing for more than a couple weeks. I prefer naproxen. So little blue pills versus little brown pills. Might be just kind of psychological that I think it works better, but I like its dosing better. It's 2 pills on the first dose and then 1 pill every 8 to 12 hours after that. So kind of twice as long before you have to take another pill as you do ibuprofen. Indomethacin, we don't tend to recommend this one as a pain med because patients don't like the side effect profile to it. It tends to have a lot of nasty side effects. And it's used more for kind of inflammatory conditions. So we would tend to think about it for things like scleritis. It is indicated by 50 to 75 milligrams 3 times a day. It's probably the only time I've ever prescribed indomethacin for a couple of patients that had scleritis, but other than that, we don't tend to see it as a pain med. Celebrex is probably the one that you see most commonly for patients who are in long-term NSAID use. Remember that there's 2 enzymes. Well, there's 2 pathways in the inflammatory cycle. There's the lipo pathway and then the cyclo pathway. And in the cyclo pathway, you've got COX-1 and COX-2. The COX-1 enzyme is really important for maintaining your GI lining, the stability of your GI system. The COX-2 enzyme bypasses that system. So if we block the COX-1 enzyme, it increases chances for gastric or pyloric ulcers. So by doing a COX-2 inhibitor, you're bypassing the COX-1 and less chance for GI issues. The downside is potentially increased chance for thrombocytic events or cardiovascular conditions. There were 2 other medications on the market called Vioxx and Bextra, which were moved because patients were dying from cardiovascular side effects. But I will tell you that all prescription NSAIDs have a big black box warning on them for warnings of cardiovascular events. Celebrex primarily used in patients who have like rheumatoid arthritis or osteoarthritis for long-term pain management. So we have a patient who's on indomethacin, has been taking it for 10 years. Which of the following is the patient also likely taking? So if they're taking long-term NSAID use, what other medication are they likely taking? And correct answer is A, omeprazole. They're taking a proton pump inhibitor. There's really 2 ways that you're going to get a gastric or pyloric ulcer at this point, and it's either NSAID use or H. pylori. With the NSAID, because it's blocking that COX-1 enzyme, it's resulting in damage to the gastric lining. So the best way to prevent that is just prevent the gastric juices from being produced. The final step in that production of gastric juices is the proton pump. So if we inhibit that, then you inhibit that final stage and you just decrease the amount of gastric juices that are in the gut. So anybody on long-term NSAID use is going to likely be on a proton pump inhibitor. Contraindications to your NSAIDs, anybody who's got an active peptic ulcer, chronic renal insufficiency, because remember, they do affect the kidneys. So be cautious in patients who are dehydrated, and be cautious in patients who have hypertension or taking blood pressure medications, because at maximum dosing, it potentially is going to interfere with their blood pressure medications, in particular their diuretics. So that alternation of 2x325 and then 2x200, I think is a great way to help patients manage pain. So after my surgery, I was given one oxycodone, and then after that, it was alternating these two. And once I got over that pain threshold, this was great for preventing me from getting back into pain. I do think in those 8 to 10 range, you need to get over the pain threshold first. I'm not sure this will do it, but once you're in that, then it helps you prevent you from going back into pain. You can do both of them at the same time. The downside at that point is they're waiting 4 hours before they can take pills again. So alternating them every 2 hours just gives them a 2-hour time window before they have to start taking more pain meds. There's your maximum dosing. So again, acetaminophen is typically 4 grams. Now it's 3. Ibuprofen is 1,200. Gabapentin, we're seeing this used a lot more, and I think sometimes not used properly because we're afraid of this opioid epidemic. Instead of giving patients Vicodin or oxycodone, are giving them gabapentin. And gabapentin's really been found to be effective for patients who have postherpetic neuralgia or diabetic neuropathy. It's really not great for acute pain, and it's not been really studied in any other neuropathic pain. I had a patient who had a recurrent corneal erosion. She was given gabapentin and it did nothing for her. So in those kind of really acute pains, I'm not sure gabapentin works that well, but is great for things like postherpetic neuralgia, diabetic neuropathy. It comes in 100 milligram and 300 milligram capsules. We don't typically prescribe the hundreds. It has a strong sedation effect to it. So if you're going to take gabapentin, it's a tighter up process. You would never give someone like 1,800 milligrams right off the bat. It's 300, then 600, then 9, then 12, 15 to tighter up to 1,800, and really make sure those first dosages are at nighttime because it has a strong sedation effect to it. Here's those couple studies I told you where the 1,000 milligrams of acetaminophen plus 4 milligrams of ibuprofen were equivalent to 5 milligrams of hydrocodone. Now that was strictly on pain relief. Remember that your opioids just bypass the body's normal pain response and makes you not care about that. So there's more of a kind of an emotional component that goes along with your opioids that you're not going to get from acetaminophen and ibuprofen. But when you're talking strictly pain management wise, pain levels, they're equivalent. So this would be absolutely what I would consider for a patient that has, kind of that 8 out of 10 pain. And then they can start the alternation of the Tylenol and ibuprofen. But remember, it has to be 4 hours after that, because these last 4 hours in their system. Then they start doing the alternation at 4 hours. So which of the following group of medications, when combined with an opioid, is one of the leading causes of death in patients? And correct answer is B, your benzodiazepines. And why is because they're sedative medications. And so when you combine them with an opioid, then when they go sedated, then the opioid kicks in and shuts down the breathing centers. So if you're ever to prescribe an opioid, you have to go to what's called a PDMP, which is a drug monitoring program. And you're looking not only for whether or not they're taking any other opioids, but they're looking for benzodiazepines as well. You'd be very cautious in prescribing someone a opioid who are taking Xanax or Valium, because just increase the probability that they go to sleep and they just don't wake up again. Side effects of your opioids, it's interesting on the kind of the sedation versus the euphoria effect that you get. Typically, it's the euphoria is when you bypass the body's normal responses for the medication. So if they're doing it by snorting it or injecting it, then it gets you into that euphoric state. For a lot of people, it tends to cause them more of a sedation effect. Respiratory side effects are the major side effect of this medication, and it's why most people will die. Is kind of a combination of, them going sedated and unconscious and then stopping to breathe. There's a list of all your scheduled medications. Remember, from Schedule 5 to Schedule 1 is the increase in chance for addiction and also potential side effects. In your Schedule 5 would be something like cough medicine that has codeine in it. Schedule 4 is tramadol, which is a synthetic analog of codeine. Your Schedule 3 are things like codeine with acetaminophen. And then in your Schedule 2s are oxycodone and hydrocodone. If you do have the ability to prescribe hydrocodone and oxycodone, the likelihood is you don't have the ability to prescribe Schedule 2s. You have the ability to prescribe hydrocodone and oxycodone because they used to be Schedule 3s and you've been grandfathered in. Very few of us could ever prescribe Demerol or Dilaudid. We have hydrocodone and oxycodone. Like I said, I like codeine. Why? Because codeine kicks in really quickly for me. I'm from Canada, so we actually had Tylenol 1s in Canada, which were 300 milligrams of acetaminophen plus 8 milligrams of codeine. And we used to be able to get those over the counter. And when it did, if I had a headache or anything, it just took care of that just instantly. So for me, I really do like codeine. What we have in the US is Tylenol 3s. Now, just note that Tylenol 3 is no longer available as a brand name. I just continue to call it that because it's easier to call it that. It's got 30 milligrams of codeine plus 300 milligrams of acetaminophen. Tylenol 4s have 60. Hydrocodone, 6 times more potent than codeine. Thought to have a little less constipation and sedation than codeine. But if you look at the study, they're really close. So I don't too sure that's really valid. There's all your different products that have hydrocodone in it. It comes in 5, 7.5, and 10 with acetaminophen and with ibuprofen as well. Oxycodone, this is the street drug. This is what people want because of its high ability to have euphoria with it. It is a very potent medication. It's almost equivalent to giving patients morphine by giving them oxycodone. So it completely bypasses the body's normal pain response. Remember, patients who are taking an opioid can become addicted to them within 4 days. It starts changing their dopamine levels in their brain. At that point, the brain doesn't feel stimulated anymore, and it needs that hit of the opioid in order to get that stimulation again. And you can't predict who's going to become addicted to them or not. There's all your products with oxycodone. It comes in 2.5, 5, 7.5, and 10. Tramadol. Tramadol is a bit of hit or miss medication. It does work for people. If it doesn't work, then you don't really know until you prescribe it. But it is certainly less potential for addiction issues. Typically comes in 50 and 100 milligram tablets every 4 to 6 hours. All right, I know I'm running quickly out of time here, but we're quickly going to do this question. You have a patient that wakes up first thing in the morning with a sharp stabbing pain, gets better as the day goes on. What would you recommend for this patient? I'll get a few of you just to answer really quickly, if you could, for me, so I can have a graph that comes up. All right, let's see what people are thinking. So the smattering of everything. So we're dealing with a corneal erosion in this point. Remember, those are usually secondary to a basement membrane dystrophy. So remember, a heaped up basement membrane doesn't allow the epithelium to stick back down. What happens at our nighttime when we sleep? The cornea swells anywhere from 4 to 10%, loosens that adhesion even further, sticks to the upper lid, and they peel it off. So intuitively, hyperosmotics makes sense to pull some of that swelling out, but people really don't like taking a salt drop. Doxy does work, but it takes 6 to 8 weeks in order for that to take effect. So on a first-time occurrence, I'm not too sure I would go doxy. Artificial tears, absolutely. As much lubrication as you can possibly get on the eye. I think bandaged contact lens is where I would go in this case. You probably want to keep that bandaged contact lens on there for probably about a week to 10 days. And when you're about to remove that lens, my recommendation is you don't go in with your fingers and pluck the lens out, that you actually flood the eye with a contact lens solution. Then you should have in your emergency kit a curved pair of forceps. And in the slit lamp, grab the edge of that lens and then peel it off. So you're not disrupting the epithelium again. Amniotic membrane, I probably wouldn't do unless I do a debridement on the person. So quickly going through RCEs and diagnosis of basement membrane dystrophy. I think the best way to diagnose them is with a retroillumination, or even better than that is negative staining. So you can see the staining pattern or the negative staining that's there. It's like having a rapid breakup, but it's in exactly the same spot every time they blink. So if you have any question about it, put fluorescein in there and just watch them blink. And every time they blink, they're going to have the same breakup pattern. And that's not common for tear breakup, but very common for corneal erosion. Or basement membrane dystrophy, sorry. For basement membrane dystrophies, we're really kind of trying to prevent the RCEs or treat them when they happen. So I have done some lecturing with Dr. Mike Greenwood, who's an ophthalmologist out of Fargo, North Dakota. It's been fascinating being able to lecture with an ophthalmologist because their perspective is very different than ours. We both agreed on frequent lubrication, as much lubrication as you can possibly get. We also agreed no fans in the room at all, no ceiling fans, no other fans in the room. And his first obviously would be PTK, but I'm doing bandaged contact lenses, doing frequent lubrication, make sure there's no fans, and then kind of see how they do. This next question is if that patient's RCE now is becoming recurrent in the sense that it's now coming back more often, it's affecting their vision. So we kind of allow a patient one corneal erosion once before we start intervening. What would you recommend at this point? And I love that we got the scattering results, which means we really don't know how to treat RCEs. But if you go to the literature in evidence-based medicine, the treatment that has the best efficacy is actually diamond burr polishing. So debridement with diamond burr polishing. We really don't do stromal puncture anymore. The stromal punctures work in the location that you did the stromal puncture. So it stabilizes it there, but in between the stromal punctures, you can get RCEs. And you're going to tell the patient, you know what, I'm going to stick this needle in your eye, not like once, but 20 times. Patients weirdly not crazy about that idea. So I haven't done stromal puncture in probably 15 years. Oral doxycycline will work. Patients with RCEs have elevated MMP9, so matrix metalloproteinase, which is a proteolytic enzyme. It's a collagen reshuffler. So we need to lower those levels down. Doxy will do that, but it takes a minimum of 4 weeks to reorganize the basement membrane. So you're talking probably 6 to 8 weeks treatment time. Debridement, getting rid of that unhealthy tissue. But if you're going to do the debridement, my recommendation is do diamond burr polishing after. PTK, basically doing debridement by using a laser. Amniotic membrane, I really do like after you've done a diamond burr polishing. So after you've kind of smoothed up that basement membrane, then put the amniotic membrane on it. No one chose nucleation. So again, doxy 50 milligrams. The study was twice a day, but you can get away with it just once a day. I would put a steroid over top of that, but remember you're waiting 4 to 8 weeks. Debridement plus diamond burr polishing has probably got the strongest evidence to show that it's the most effective to prevent other RCEs from developing. With debridement, I have the access to an autoclave, so I can use something like a platinum spatula. You certainly can use things like Wexel sponges and so on. I just find the spatula works better. And what you want to do is you're going to put Preparic in the eye. And remember that this tissue is really necrotic. It's not really healthy tissue, so it sloughs off pretty easily. But what you want to do is the motion you're doing is like buttering toast. You're going to move from the outside in, and that's the movement you're going to use. Now, before lecturing with Dr. Greenwood, I would just debride the area that I think is eroding off. And he's going, Blair, you have to go probably twice that out. He says, think about it as, you know, say you're going to replace a section of your carpet, a spot on your carpet. Well, it's going to be really noticeable where you place that. So really what you need to do is actually replace the entire carpet. But he's going, what you want to do is actually get into healthy tissue first. Because when there's the new cells come across, they stick down better. There's no actual border between what was unhealthy and what was healthy. The diamond burr, you can get it from a company called Catena.com. That's not the company anymore. They've been bought by someone else, but if you type that in, the company will come up. And what you're going to look for is, it's also referred to as a pterygium burr. And what you want is the largest ball you can find, which is a 5 millimeter ball and fine grit. And the study you can see here is that a single treatment with diamond burr polishing reduced the recurrence of the RCEs, the corneal erosions, by 95% over the next 3 years. So it's really got the strongest evidence to prove that it's actually effective. The last thing I want to show you is a quick video here. This is Dr. Greenwood, who's doing a Saltzman's degeneration. And I'm just going to fast forward it to the diamond burr polishing. See how the cornea is hazy here, that there's kind of this epithelium just looks a little bit hazy. But when you start the diamond burr, this is a large ball. It's not like your algae brush. This is never going to penetrate the cornea. So it's kind of like the difference between sanding your floors and then polishing them after. You're not really removing tissue at this point. You're just smoothing it out. And you see as it goes across, then the epithelium starts to clear up. So what you're getting rid of is those loose epithelial cells. But what else you're doing is you're stimulating the basement membrane to be sticky. So when those new epithelial cells come from the limbus, they have a nice smooth tissue to go across, and then they're locked down into place. So you can see how the cornea just clears up with this. Kind of the worst part for the patient is the whirring sound of the burr. And remember, this is a 5 millimeter burr or ball. So the area, we don't tend to do limbus to limbus, but it's really just kind of, you're almost spot doing it because likely your debridement is probably 5 to 7 millimeters, and you're just kind of just doing that area. And then after that, I think an amniotic membrane would be perfect at that point.